I'm going to go back to the focus notes to finish up just a little bit on adaptive immunity, but I don't want to flip between projector and board, projector and board, projector and board. So I'm going to do everything I want to do on the board first, then I'm going to pull up the projector, which will be a little bit of review as I come to the parts I want to talk to you about. Okay? And the other thing I can't do is our projectors, if you turn them off, you've got to wait 10, 15 minutes for the light to go before you can turn it back on and you're going to blow it. So we want to be sure we don't do that. I'm going to start with, excuse me, there you go. Chapter 17, which is a bit about vaccinations, now called immunizations, and about testing. I will hand this handout out when I get to it this morning. Everybody settled in? Everybody okay? First, concept. Herd immunity. Herd immunity. This is one of the things that is decreasing in the United States, as far as we can tell. All over the internet, it says, if you vaccinate your child, you're endangering your child. Do not vaccinate your child. CDC says what? Vaccinate your child. School system says what? Vaccinate your child. Can things go wrong every so often? Yes. It can happen in my family or your family. Nothing's perfect. But herd immunity means, I'm going to just draw it here. And you already know this. It's just sort of a simplistic drawing. If you have a town and a lot of people are vaccinated, a few people are open, which means they or the family have not been vaccinated. Somebody flies into town or somebody drives in from the next town to come through the car. There you go. I can't draw, it's not my art, okay? And they're sick. As long as you have the vaccinated people above a certain percent, what happens to that illness when it gets in? It has no place to jump, to infect, and the illness stops. That's called herd immunity. Something like 70%, and the numbers can change depending on who you're talking to. CDC was like somewhere around 70% of the population vaccinated or have had the illness and be immune. What if your town's opposite? And many, many people are not vaccinated. Maybe one or two. Somebody drives into town that's with that illness. What's going to happen in that case? Will spread like wildfire. This is a balance, and yes, I understand it's a balance because every individual is important, and you have to balance that with what the community needs. And that's a hard call sometimes. And I'm not in ethics, so we do have to do in ethics here. So that's what herd immunity means. Have a certain percentage of the population vaccinated and immune so you can prevent the establishment and or creation of some sort of epidemic. And that's just a definition. Now, I'm going to go into testing. What if you want to know if a person is sick, has been sick, or what you need to do with your population about vaccinating? Of course, back on this cow, vaccination started with who? Jenner. Because he took the what pox? Cowpox and vaccinated for smallpox. They now call them immunizations. There are two types of testing that people tend to do, and I'm going to go over the big ones. Direct testing and indirect testing. Well, we're talking about the immune system. You have antibodies that have to be produced if the person's been infected, right? Then the actual pathogen will have antigens or epitopes which trigger the response. If you do direct testing, you're testing for the pathogen or a piece of the pathogen, straight for the invading element. You're doing indirect testing, you're doing the body's response, you're hunting for, excuse me, the antibodies. The antibodies in the serum.
Is that the titers? That's right.
That's one type of titers. There's a whole bunch of different types of titers. Yes, that is one type. Now, the other thing, that's right, and we'll just wait until it's okay. Why would you check for antibodies? Why don't you just always look for the organism? Because what do we say about spirochetes, for instance? They can hide. But the body knows they're there. So the body has built antibodies. So you don't hunt for the organism that you can't find, you hunt for the antibodies. That's indirect testing. Antibodies being present, however, have 3 different meanings, not one. If you do direct testing for the antigens or the pathogens, excuse me, I'm sorry, I always seem to have frogs in my throat. 3 things here. Well, direct testing means you've got to have a pathogen. Indirect means 3 things. You may have the infection or have had it and are well. What's the third one? The headache, vaccination. So 3 things. If you have a positive indirect test, doesn't mean the person has to be sick right now. They could have antibodies. What are memory cells? B, memory cells. They want to remember. They want to remember. Now, I'm going to go over, I used to teach these differently, but I think it helps out with the neutralization test if I draw them on board. This is also a straight linkage to your handout on how antibodies kill under neutralization. But they actually don't kill, they just protect. Viral, in this case, neutralization test, is what I'm going right here. Viral neutralization works like this. If you have some sort of piece of a virus floating around, there are certain viruses, from neutralization, that if you have regular old cells, will cause the cells, you remember lytic? Will cause the cells to break open. Lysis. So that's what happens in your lab if there's nothing else there. Take some sort of these cells that are sensitive, because when we talk about the lytic cycle, expose them to the viruses replicate, break out, and destroy the cells. But what if you want to know if your patient has antibodies to that virus? You add a new element. In this case, you have your virus, okay, probably store-bought, you have some sort of regular old cells, probably store-bought, and you go to your patient. You take serum out, and often the term antisera is used because it has antibodies in it. Take the sera out. If your patient has no antibodies and it's clear, and you mix these 2, the cells are going to crack open, right? They're going to lyse, because that's what naturally happens. But if you do the same procedure, virus is a terrible drawing, plus cells, plus from the plasma or the sera of your patient, and they have antibodies. The antibodies are to that virus. So what do we say? The antibodies are going to tie up the virus. They're going to cover the docking ports, the recognition patterns on the virus. And the viruses now duct taped are tied up, correct? Because a virus has to attach to infect. So their tissue cells, whatever they are still floating around intact because the virus cannot attach. And if it can't attach, it can enter, it can lyse. That way, if you get lysis of the cells, your patient does or does not have the illness. One of the two. Get lysis of the cells, your patient does or does not have the illness. Does not. Okay, that's all right. If you keep cells whole, that patient had to have what in their blood? The antibodies. So they may have the illness, they may have been vaccinated, or they may have gotten it and gone well. That's the first one, the neutralization test. It works for different types of viruses. One of the ones they use it for is hantavirus. No more for places out west that are dry, hantavirus. Now then mouse droppings. Well, if in a dry area, the mouse leaves a dropping, it turns to dust very soon, doesn't it? Then we talked about it blowing up, people breathing it in. So respiratory virus. Everybody okay with this one? Well, for the next one, it's called viral agglutination. It's the same idea. Same idea. Except there are certain viruses that are known to cause red blood cells to agglutinate. What does that mean? Agglutination. Clump. Clump. All right. In this case, you buy a virus. You have several of them. In this case, it is red blood cells. And this virus will naturally cause, for whatever reason, it will cause clumping in a sort of matrix, and everything sticks together. So you get agglutination. Okay? Now let's think about your patient. You want to see if your patient has this virus, or has had this virus in their body. Do the same thing with adding that extra factor. You have your virus plus red blood cells, which if nothing else is present, they will clump. That's called hemoagglutination, because heme is blood, agglutination is agglutination. Add from what for your patient? Serum, and they may or may not have antibodies. If they have antibodies, the antibodies are going to do what to the virus? Attach antibody-antigen complex. Tie up that virus, cover its docking ports, its protein receptors or its glycoprotein receptors. And what happens to the red blood cells? You should know red, not red though. Red blood cells stay free. They just float around, float around. So this person would have the illness, correct? They would have the illness. What if the person didn't have the illness? Would this be what happened? Yeah, because there's nothing what? And the virus would again cause hemoagglutination. Okay. Direct test for the pathogen if you saw. Indirect test for the antibodies. These two neutralization tests are the indirect or direct test. The test for the antibodies, so they are indirect. That's okay. It's the first time you heard it, right? It's not fair to teach somebody one thing and then say, there, you got it. Right? That's not quite right. Okay, I'm now going to move to the handouts. And then I'm going to ask the has this. This says types of vaccinations. Types of vaccinations. Who needs one? Okay. If I hand you one and you already have one, please pass it back to the people behind you. You can pass it down and over. Down and over. Anybody else? Types of vaccinations. These two boxes has a list right here. There are some not as important ones that maybe subjective on the back, but the two big ones are these two boxes right there. Yes, absolutely. And pass this one. And pass this one and down the back. Okay, something's happening when I'm getting the people. Hold on. Get out. Come in. And it says types of vaccinations, attenuated line, and inactivated field on the other side. And we're still passing. Everybody else. It's all right. It's well here. All right, still what you can use a handout. The big difference is, it's off our hand. The big difference is these two. Attenuated means alive but weakened. Alive but weakened. The inactivated or killed means what? The pathogen has either been broken into pieces or has been killed. There are several things very important that are associated with this. Okay, one, for attenuated. They weaken them. And this happens in nature too, in families and in school systems everywhere. Usually as a pathogen passes through people being sick, not always. A pathogen keeps killing off its target. How long is it going to be around? Not very long, because it's killing off its food that doesn't reproduce. So often in nature, in an illness given time and the population is not destroyed, the naturally pathogen will attenuate, get weaker, and learn to live with us, make us some sick but not kill us. You can take this into a lab. To attenuate, you can pass these pathogens through chicken eggs, pass them through tissues, pass them through multiple hosts, which essentially is what's happening in the world. Or you can actually speed it up and treat them with some radiation chemicals and make them weaker. The point is to give the person a mild infection, and the immune system kicks in and you're immune, but not give them the disease. That's the best immunity. That is the best vaccination. Gives you the longest memory, gives you the best protection. There's a flip side of it, you already know. No matter how careful they are, and they tend to do studies, and sometimes they know the numbers, a certain percentage of the vaccine will revert. What did I say? A certain percentage will revert to the original form. Some people are going to get the disease. The some will always revert to full pathogen. But it gives you the best protection. It also gives you community protection. We're talking about herd immunity. Because if I have it, if you have it, we have a mild infection. Sometimes if we're sitting close to somebody else in our family or movie theater, we're shedding the organism. But we're shedding the attenuated living organism. It can actually vaccinate some people that are close to us, and that can help get vaccination through the community. So that's actually good. Bad side is the reversion. The United States, as it goes down here, back in 2000, sending out a polio, thought they were helping people, attenuated vaccine from the virus. As far as they tell, most, if not all, of the vaccines reverted. It was not intentional. What happened? Every person got the illness. At that time, the United States said, we're going to move to the other one, which is the killed whole or subunit vaccine, at least for polio. So everybody okay with attenuated? Attenuated means weakened, but a lot. Best protection. Now, if you're moving over here to killed vaccines, there are two types. In one, you kill the organism, you inject the whole organism, whole organism into the person. And the other one, you either you take the organism and you break them up into what? Epitopes, pieces, subunit vaccine. Subunit means pieces of. Now, why you can't do one or the other each time and always is because there's another balance you need to follow. The bigger the antigen and more complex, the more the immune response. The smaller the antigen, the less the immune response. You've got to find that place in the middle. Pertussis, at least in some times, used to be a whole killed vaccination. They stopped often giving that one, and it was killed, because at the site of infection, the site of injection, it hurt. It hurt because there was a whole killed, and the body gave a very strong response, and people, if a person's shot hurts them a couple of days later or the day of, are they likely to keep getting shots? No, people avoid needles to begin with, they avoid pain too. That's natural. So they switched it to a subunit, which means you have smaller pieces of, still get an immune response, but not as much that you're getting as much pain at the site of injection for pertussis, which is what we call it. Now here's the flip side problem. If you're going to a subunit vaccine, which means pieces of the pathogen, or epitopes of the pathogen, it can get so small that you're not getting an immune response, or not enough of an immune response to protect you very well. So if you have something small, sometimes you have to make it bigger to get an immune response. And you tack on a protein or tack on something to it to make it a little bit larger. come down here, you can have an adjuvant added to a point. Sometimes that can be a hapten. You can see some of the handout letter, H-A-P-T-E-N, which means make the subunit larger. Or an adjuvant can just be another chemical in the vaccination to help give a better immune response. Then we get into the next discussion, which is a fuss. Some people say some of the adjuvants, you come down here, are causing problems and causing autism and all sorts of problems for the person injected. And they're going to have to go back to reading some research studies, find out what's really going on. Sometimes they do put a trace of mercury into some vaccinations, only a few, to help with the vaccination. Yes, mercury buildup can do that. But it's been working for a long time, and there's no research on the subject. And some people are claiming that's causing a lot. But you have to find the balances. Subunit vaccines and whole killed vaccines, which are right over here, which are called inactivated, because that means they're dead, do not give as good of an immune response. That's why with your tetanus, you have to have a 10-year booster. You have to have boosters. And sometimes boosters are 5 years, and sometimes they're 3 years, and sometimes they're less. It also depends on the person. Some people may lose their immunity sooner, and some people may hold it longer, but there's not a given known for that. Everybody okay with this? Now, please, you know that looks like a good matching section. You have attenuated live and its characteristics and points, and you have inactivated, which can include subunit and whole. Think about the logic here. If this logic point worries me. If I say subunit vaccine, it means a piece of. Can a piece of something be alive? No. If I have a deer and I have a piece of its hoof, is that alive? Well, as an independent, I don't know tissue on it. As an independent identity, no. The subunit, by definition, has to be dead. Has to be dead. On the back, I'm going to go over these just briefly. Remember, toxoid vaccines, you can have an organism that the organism is not so much affecting you as it's producing a exotoxin that's going through your bloodstream. We tend to protect ourselves from toxins with what? If you're on board, a little Y. Antibodies. Antibodies tie up what? The docking ports, the receptor proteins. And the toxins cannot harm us. And yes, you're going to have, since it's so small, since I say small, you think often need more shots. Right? Okay, you can make a inactivated toxin stimulate the what? The antibodies. I said small, fewer determinants. Okay, and you do the inoculation. Genetic, all I'm going to say about that is that can be a way to make in mass quantity subunit vaccines. Take the epitope you want the immune system to go after. Maybe the H or N spike of a virus. Place it into the little teeny factory called E. coli. Get E. coli to make just that one little subunit. This is an example, they're not doing this because of the work of life. E. coli produces that one little subunit in massive numbers. Purify it out. You don't take the E. coli. Purify it out, and there you have your subunit vaccination. That's what all this means right now. For the other ones, you know about DTaP and MMR and all those. Because they're combination vaccines. Combination simply means they have more than one. One. More than one. More than one. Okay, now I'm going to, let's see, I'll do this in sequential order. Excuse me. I'm going to go to the focus notes, and then I'm going to come back and draw the board again when we get to the next chapter. I'm going to wake this up. It should start humming. Still the chapter on vaccinations, but these are the got a couple more. I'm gonna finish up the first one. So we'll do some. This one's very important. Another test. This is called the ELISA or ELISA. I've heard it both ways. It detects either way. Think about it. If you have the antibodies, you can find the antigen, the pathogen. If you have a piece of pathogen, you can find the corresponding antibody. As long as you have one, you can find the other. So this test actually can flip. You can decide to hunt for the antibodies in the person's blood, or you can decide to hunt for the pathogen. I'm going to go to the person's blood. You can flip it either way. Part of it you buy from the store, part of it you get from the patient. I'm going to do the indirect test. You're a little bit loud, so I don't have the sound right. Okay.
The assay, or ELISA, is a commonly used format for serologic testing. The purpose of this animation is to explain how this test works. ELISA serologies are usually done in multi-well microtiter plates so that dilutions of serum can be easily prepared and tested. To better understand how this assay is done, let's take a closer look at what happens in one of the wells of this assay plate. To perform the assay, the wells of the plate are coated with the antigen of interest. For commercial tests, this would be done by the manufacturer of the assay. To begin testing, the wells are filled with dilutions of the patient's serum. If antibodies against the antigen are present, they will bind to the antigen fixed to the bottom of the wells. But only antigen-specific antibodies will bind to the wells. The wells are then washed out to remove all unbound antibodies. Next, a solution of an animal antibody against human antibodies is added. This second antibody is covalently conjugated to an enzyme. The wells are washed again, this time to remove any unbound enzyme-conjugated antibody. Finally, a solution of a colorogenic enzyme substrate is added. The interaction of the substrate with the enzyme on the second antibody generates visible color. The development of color in the wells for the specific antibody can be seen with the naked eye or quantified with an electronic plate reader. The reaction is less intense as this.
Okay. I'm going to go through it again. I'm just going to show you the pictures. Get that for a moment. Okay, we have some sort of well. It'll be good. You buy from some sort of scientific company a piece of the antigen, a piece of the pathogen, right? What you're really going to do is you're going to hunt, you're going to use a flashlight. When you get from your patient, I'll show you this, you get the antibodies from your patient, you know that. Oh. Try not to go too far. In the patient's plasma, you get antibodies. If the antibodies are present, antibody will form antibody-antigen complex and link. And remember, you rinse between times. Any other antibodies your patient has to other illnesses don't matter because they won't link, the jigsaw pieces, docking parts don't match, and they'll wash out in the wash. So right here, you decide whether your patient has a matching antibody, right? Next, come up over here, going to do your wash. Do that a little bit. And you have the next section. You add a solution that's store-bought with an anti-antibody. This is where it gets a little bit interesting. This antibody sees this as an antigen because it's a pattern in it. This has been made in the animal or tissue culture. They injected it with what? Whatever the pattern was for the epitope. They got it to produce what? Antibodies. They then injected the antibodies into something and made anti-antibodies. So an antibody goes after a piece of a pathogen or epitope. But it itself is still a pattern, isn't it? So you can actually have antibodies to antibodies. And that can be serum sickness in us. If we're ever given, remember the toxoid vaccination? We will be given antibodies to protect us against a what? Toxin. What if our body sees those injected antibodies as foreign non-self? Then it goes after it as an antigen, and we make our antibodies to the antibody, and we get sick. So it gets very involved. But anyway, these are going to match. They're going to link. He has on the end like a flashlight, a little color change, and we're forming a sandwich. All the pieces of the sandwich have to be there. Store-bought, specific type of disease you want to see. From your patient, has to be in the serum. He's going to link here, and you'll have a sandwich with 3 layers. Then you rinse, and you rinse with a new colored dye. You have the link. Everything's going to rinse away except everybody that's linked together. When you add the special fluid, this little flashlight or enzyme makes the fluid change color. Remember how we went from what, red to yellow, something like that? Will cause the entire fluid to change color. So all these have to be present if what's present? Antibody. You get the color change if what's present? The antibody. If this,
It's only used for to find if the antibodies in there.
you can switch it. Switch it this more. Switch, you put antibodies here, hunt for a piece of the pathogen here, and then hunt for an antibody with a flashlight on the end here. You can do it for direct or indirect. But this is indirect. So for this one, if your patient didn't have this, and you wash, because you wash between times, everything washes away, this would be taken in, but what would be missing? The antibody. Would he have anybody to attach to? No. So when you wash, everything washes away if there's no antibody in the patient, except for this, which doesn't do anything. And you get no color change. You want me to run it one more time? Because this is a little bit of a different way of thinking. And yes, you can switch it. This one, you're hunting for antibodies in the patient. If you want to search for a piece of the pathogen in the patient, put antibodies bought from the store. Basically, now direct testing. Then get your sample from your patient. If they have the antigen, it will link to the antibody. Then you buy from some sort of store the antibody to your patient's possible pathogen. It would link. Put that little color changing fluid in there, and if this one's present, this causes the color to change. The whole point is anything in the middle of the sandwich is what's important. If the antibody's there, your patient has or could have had illness. If the antigen's there, your patient could or could have had illness. But if that middle part of that sandwich is missing, everything washes away and you don't get a color change. Very elegant. Very elegant. Okay? So hopefully that will help. Now, the next one I want to show you is called the Western blot. And this is straight from your textbook. Straight from your textbook. Western blot. It's very involved. All of this is just a procedure to separate out the possible antibodies in a person's blood and then to transfer it from a agar-like gel to strips of paper that can be tested. That's what all this comes down to. And I tell it to you, but I'm not going to test you on knowing how to do the electrophoretic method. I do want you to know the outcome, what this means. What this means. In this case, polyacrylamide gel. It's like agar, but it's thicker. You make little holes in one side. They're called wells. You take, well, you pretty much take from your patient samples from your plasma, from your serum. You load it into the wells, and you literally put this into a buffer with a little bit of fluid in it, and you run an electrical current across it. I told you I'm not going to test you on the procedure, but I'm going to test you on the outcome. Well, they're going to run. Each one has a starting place. Patient 1, 2, 3, 4, and 5. Let's say you're testing 6 different patients. You put the electrical current from plus to negative or negative to plus, and they start running. They start running what? In their lanes. And the different proteins / or antibody antigens will drop out according to, bigger ones will drop out what? First or later? They're bigger. They won't carry as far. they'll drop out first. But there's also a charge, so charge has an effect here. The whole point is separating out proteins in our antibody antigen complexes in each lane being a patient's sample. Everything from here to here is the fact that you can't work with gel. If you try to pick up gel a lot, it's going to do what? Fall apart. So they try to make a copy, a Xerox copy of what's separated out on the gel onto paper called nitrocellulose paper. Well, how can you do that? That's real easy. You take right here a sponge. You have here, you have your dry filter paper, hard filter paper, and you put the nitrocellulose in between, and you have your gel here. Water does what? Goes from the wet sponge through the gel. It goes through the gel, it's going to paper. What's it going to take from the gel to the paper? The bands. The bands. It's just going to carry them over in the water. You don't move anything, so everything's a copy. You don't move anything, so it's an exact copy. Couples up, you get patient 1 through 6. As you have a positive control, let's make something up, maybe for pertussis. If this is your patient, and this tells you this person has pertussis, does this banding indicate your patient has pertussis? You have 2 in room 26. What if you have patient 3 in room 18? They have. Has what? Habits match. With habits match. All this is just separating it out and transferring it to paper. What matters is finding the matching pattern to whatever disease. And you can do this for different diseases. It doesn't have to be this one or that. It's called the Western blot. This is in your page. This is in your book. This is straight from the book. Yes.
So 3 is positive, but he doesn't have an exact match.
He's
Does that
close
matter?
enough. No, close it counts. Because this thing's not going to be perfect. If it's that close, it'll be a match. But
So
you're right.
5 and 6, even though they have more than, let's say, 1 and 2, they're not a match.
I'd still go for 3. Okay. And then, of course, it depends on diseases, too. You may read them a little differently for each
So
disease.
how does it tell whether the disease is progressing, or, you know what I mean? Like,
No, I won't tell if it's progressive.
because like, that could be the person like number 5, where he has more lines than all of them besides.
That's a good point, but no, I won't tell if it's a new infection not yet established, or if he's got to be well into the disease to get all this out. Think about antibodies. Think about antibodies. Antibodies only produced after what? 2 to 3 weeks of infection. So yes, I guess you're right. The disease has to have progressed to a certain point. That's true. If it's too early, you won't
That's what
have
I'm saying, if
antibodies.
it's too early, you might not have enough antibodies.
You might want to check them again. You might want to test them 2 weeks and then 3 weeks and see what happens. Probably a good idea. That's a good idea. So remember, this only works if there's a well-established disease, because we're looking at antibodies, that's 2 to 3 weeks. Yes.
So someone was she was saying when she was telling her that a patient can have a negative control and later on the retest can become
Well, the
positive.
control is not the patient.
Well, have a negative like
Outcome.
outcome, and then later on when we test them, they can become positive.
Yes, because when do antibodies show up? 2 to 3 weeks after the infection starts. So if they're in the first week, there may not be enough. We'll just check them again. Yes.
What about diseases that take years to show up, like AIDS, for example?
2 to 3 weeks. As soon as the body builds the antibodies, you're okay. But yes, it could hide for a while. Is this perfect? No. Is this a test? Yes. None of us, they're not going to be perfect. And how about some with syphilis, some with Lyme disease? All of them. Gotta catch them. Okay, everybody okay with this? This is immune testing. I want to draw one on the board. I have to come back to that. I'm going to switch over now to the chapter and the focus notes. Part of this will be a review. Part of it's going to be new. The part I want to draw is I'm even going to show you, but I'm going to draw it when we get back to the board. Vaccinations. Herd immunity, about 70–75% vaccinated, people protected. That's a goal for the CDC. Do they get it? Not as much as they used to. Past immunization is something we've heard about before, which we're also going to bring up when we go back to the cytokines in the chapter on adaptive immunity. Passive means you've injected antibodies in. The person is protected, unprotected forever. Antibodies. Only as long as the antibodies are flowing through their bloodstream, through their body, bloodstream. Because what's going to happen with antibodies? They're going to fall apart. There are no B cells. So you're only protected as long as you have active antibodies. Hybridoma, which is something to know about, sometimes they fuse other cancer cells, so out of control, endlessly replicating cells. What if you wanted, you have a plasma cell? Where do plasma cells come from?
B cells.
B cells. They produce antibodies that go after a what? A certain target. What if you want an endless factory? What if you want an endless factory of antibodies to give to somebody to protect them with passive immunization? Sometimes they're thinking about this: fuse a cancer cell with a plasma cell that produces what? The antibodies. And you get an endless supply of antibodies. Our cells eventually will stop programmed cell death apoptosis. Cancer cells never stop. And that's one thing that's called a hybridoma. Okay? Now, direct and indirect testing, we went over. A glutination test, we've already did that in another chapter. That's antibody-antigen complex. Cross this out in the focus notes because it's actually exactly opposite. All I want you to know is that glutination is that little fluid on the glass slide or the glass plate. Precipitation is a white line on a plate, an agar plate. But both are based on what? The antibody-antigen complex, or less. Both are based on that. Titration is what I talked about. Here's your neutralization test with your viral and your hemagglutination. We threw that on the board. It was up there. Complement, I'm not going to go over because people aren't doing it very much right now. I'm going to not test you on that. We talked about ELISA. This is just a long-term definition on a procedure for what happens. This confuses people. I find that the movie, bless you, the movie are drawing on the board showing each step happening makes a lot more sense than this. But that's the textual explanation. Western blot, same thing. And the next one I'm going to draw on the board, so I'm not going to show it to you. I'll keep it a surprise to you. That's that chapter. That's that chapter. We're now going to go. So y'all are worried there's going to be too much material for the test next Tuesday, weren't you? You don't have to do anything. But we're going to go to the next part now. I'm heading for immune disorders. Focus house. Focus house. Before I even do that, this is the classic I want you to see. This is from the textbook. It's the basis for many of the allergic responses. And first, an allergic response is the same thing as your response to an infection. What's the difference? Pretty much nothing. Same response. The only thing is, instead of a bacterium or a virus attacking us, we have a piece of the environment that comes in and makes our immune system trigger. Those are called allergens, technically, instead of antigens. So they're still antigens, aren't they? They're still antigens because they cause the immune system to respond. This is a classic IgE allergen. And it goes through adaptive system coding, doesn't it? It's right behind it. What do you have? What's APC? Antigen presenting cell. Breaks down what? In this case, it's not a virus or bacterium. Pollen, peanut butter, dust mite feces, whatever you're allergic to, right? It's going to present, what do we say? Flag-based MHC with epitope. It's going to present, in this case, we're going to do the relay race, which means it's the humoral immunity. And we're going to have a TH cell that's going to be activated. It's going to release an interleukin, that's what IO stands for, I get to that in the cytokine list, which helps everything activate and makes a stronger response. It's going to run and tattletale to a B cell. Now, see, we're not talking a bacterial infection, we're talking an allergen. Okay? B cell is going to become a plasma cell. so I'm gonna go back to memory. Plasma cells produce antibodies, except at this time, it's IgE. E is an elephant. IgE. E is an elephant. I said these antibodies and or immunoglobulins can either be flowing through your blood or they can be stuck on what? Surface of your immune cells. One immune cell is this huge, filled with little black, or this is purple, insoluble complexes of histamine called the mast cell. They're going to stick, because antibodies always stick to the immune cell by the FAB or FC part.
FC.
The FC. See, everything's starting to fall into place here. Do you already know this? And of course, they can help with the basophil. Basophil is going to help secrete more chemicals, and your inflammation process is going to go off, because basophil is not phagocytic. They're going to help with the eosinophil, which is, this is good, but this one's not. Okay? He's going to help kill parasitic, help recognizing and kill parasitic worms. Here's the allergy. First time, nothing happens. Coating. Next time you use peanut butter, or you breathe in the oat pollen, there's always oat pollen here, or dust mite feces, which are terrible. There was one thing I read, that people don't change the pillows for like 20 or 30 years. By the time you don't change your pillow that much, you can probably weigh the dust mite feces, probably 2 or 3 pounds. Okay? People don't change their mattresses ever. Sometimes. I mean, ever. Think about the number of little bugs in the parts of it. Next time, you breathe in the oat pollen and put your head on that pillow. This is technically an antigen, but because it's not an invader, we're calling it a allergen. It's going to what? The FAB portion links to the pattern that's not self, in this case an allergen. This is a trigger, like touching your cell phone. It's going to send a signal inside the mast cell. These little insoluble complexes are going to become soluble and released into your bloodstream in massive numbers. Well, not numbers, concentration. Histamine. Histamine is an inflammatory chemical. What's going to happen? Your eyes are going to water, turn red, itch. You're going to sneeze. The entire allergic response. Not the first time, the next time. And then there's also what? Memory. So the third time, worse. Fourth time, worse. Does that make sense? So that's a beautiful picture. That is one of the clearest pictures I've seen in that textbook. Now, immune disorders, this is what we did. We already talked about APC. That was that whole picture, because I like the picture instead of just giving you flat, dry text. The allergic reaction. I apologize. Oh, there's one right there. Autoimmune diseases. Common in older people and women. Older people, because the immune system is starting to break down. Break down. Controls. The TR cell does what? Regulates. Now, they're not quite sure why ladies. The thought process, and I'm just telling you, they think, because I'm not going to tell you something is true when they haven't proven it. What they think, and especially is true for ladies who have had children, because there has been non-self patterns in the person's body. And later on, they're thinking these non-self patterns in some way they don't quite understand are causing autoimmune. Notice the autoimmune, his body's attacking self. Body's attacking self. Environmental, okay? Here's what you're going to hear again and again and again and again. This is the current thought. They also think some autoimmune diseases means a person had a strong viral infection sometime in the past. It may be months, it may be years, it may be 10 years, it may be 15 years. But viruses go in, take over our cells, and they cause our cells, don't they cause our cells to slightly change if they're still in there? Aren't they changing the patterns on the surface just a little bit? That could be one of them right there. So ladies who have children especially, older people, and of course as some sort of virus. This one over here, get that R out of there. Sometimes the patterns on an invader are close to patterns on certain parts of our body. The one they're worried about is strep pyogenes, get the R out of there. Has similar patterns to on our heart. Sometimes if you have an infection with strep throat, the body starts to see some of the patterns on the heart as strep. What's it going to do? Attack. Now, there was one researcher about a year and a half ago that says that's malarkey. He said that's not true. But everybody else is still saying it is true, especially the dentist. So right now, most people are saying this is true. With one person who I haven't heard from in about 6 months, so I don't know. He just switched that up. Also, the virus can help trigger. MHC, what does MHC do? One helps present state of activation, but also helps identify who to attack as part of your regulation control. What do we say about clonal deletion? If the MHC is incorrect, the cell line should be destroyed from the get-go. But if that's not done, and your MHC is incorrect, your flag-based, you could have incorrect control of your immune system, therefore you can get autoimmune disorders. Okay, that's where the next one overlaps. Two types of autoimmune diseases, systemic and single organ. Lupus is a systemic, but lupus is hard to pin down. And I'll go over that on one of the handouts. Okay, for single organ, if you go after the red blood cells, you're going to get what? Anemia for the first blood. Endocrine organs, think about your thyroid, other eyes and Langerhans. Nervous tissue, connective tissue, you're probably headed into Parkinson's and other things like that. The attacking on red blood cells, that's considered a single cell line. You get anemia. I'll come back down to here. Why would your body attack its own cells? Some drugs, and there's some that they know about, some they don't. You have to have your computer program for that. Will slightly change the patterns on our cells. Not most of them, but some. Will slightly change the patterns, say, on red blood cells. If you change the pattern of self on our red blood cells, the pattern is now not self, it is non-self. Same thing if a virus went in. Change it slightly to non-self. What's the immune system going to do? It's going to attack. So sometimes certain drugs, if they change those patterns, it says alter the service. You know what it means. It means the recognition, jigsaw pieces, receptors, and it can happen. IgM can attack. And of course, you get everything else. IgG, IgM, binds the red blood cell. You're going to lyse it. How does complement lyse? In this case, complement cells. If complement's lysing something, every one of the 20 proteins has to do what? Drop into place. You have to form the, you have a three-dimensional donut, you open up what? Holes into the target. What happens to the red blood cell? And it was all started by who? In this case, IgM. IgG can act as an opsonin. Opsonin can be two things. Attack one alone, or can be a handle so you can grab it, bring it in, and destroy it. Well, that's going to promote phagocytosis for sure. And you have problems there. I'm not going to go too much deeper into that. I am going to go deeper into these. Islet of Langerhans, pancreas. Why do you need that? Insulin. Need insulin for keeping your sugar levels right. If that is not working, you have the disorder called diabetes. What if your body, and this is what it says in the book, they think there was a viral infection somewhere in the past, and they have changed the surface patterns. The body goes after and destroys the islets. Islets are destroyed, you no longer have production of insulin, you get diabetes. If you can catch it soon enough, you can use immunosuppressant drugs to stop the body from attacking what? Islets. But you gotta catch it in time, because once it's destroyed, is it gonna come back? No. That's one of them. One of them. Okay, going down to the thyroid. Please don't think the thyroid's over the heart. That's the thymus. Where's the thyroid? On the other side here. This helps pretty much control your metabolism. You're gonna have hyperthyroidism or hypo. Hypo means too low, hyper means too high. And neither one is good. And oddly enough, both of them will make you feel tired, even if you're producing too much. Coming here. Okay, of course you're going to have antibodies that attack overstimulation when you use hyper, that's your Graves' disease. A goiter means you have like a special sort of swelling around the throat. Rapid heartbeat can damage other organs too, not just the heart. I said fatigue, even though your metabolism is running faster, you think they give you more energy, it just makes you tired. This is not the way to lose weight. This is not the way to lose weight. And you're going to have to treat it. Anti-thyroid medicines, some people do what? They use surgery and they take out. If you take out the thyroid, what do you have to give the person for the rest of their life? Medicine. Synthroid is the commercial term. It's also generic as levothyroxine. But for the rest of their life, you have to have blood tests to see where their levels are.
That's where I fall. Yeah, yeah. And that's what my mom takes for hypo. I have hyper, so it depends on
The
how
person.
your body processes.
That's really how it processes it. They watch it all the time.
Yeah, you have to take it
Every month? Okay. You know, some people have to go every 6 months, but every
No,
month.
not with hyper.
Okay, no, hyper.
My mother goes every 3 to 6 months. She has hypo, but I'm hyper, so.
So you have levothyroxine.
Yeah, and my levels could rise to the point where it shuts down my organs, which would be this thyroid storm, when they call it, and everything just starts shutting down. So you have
You know there's a fight between Synthroid and levothyroxine for hypo.
Yeah. Well,
Ever
with
heard
hypo, the problem is that eventually your thyroid can burn out. So the same thing with hyper. If you have it more commonly with hyper, it burns out, doesn't work, and now you're on meds.
But not that aspect. Some endocrinologists say this. That's good information. Hypo, which is too low, levothyroxine. And they check your blood. They always say generic medicines are the same and as good as what? The brand name. Some endocrinologists say that's not true for Synthroid and levothyroxine. Some say it is true. Some say that it's not that they don't have the chemical in it, but they will change the amount of levothyroxine in the batches a bit more than they would like in the levothyroxine, whereas the Synthroid's kept to a narrower concentration, so you know you're getting about the same each time. But Synthroid costs more than levothyroxine, so the other balance is the economy of the patient. And they'll do a blood test, and they'll watch. And some people can use levothyroxine, and they'll keep in that range for the thyroid hormone. Some can't take it, and they go up and down, up and down, up and down. And they have to go to Synthroid or what. That's another one. Talk about this. Multiple sclerosis, we're heading into nervous tissue. Okay, immunodeficiencies, we're going to head into this one. First one. Problems with the adaptive system. If a child is unable to make the great-great-great-great-grandparents of both B and T cells, you get no what? You get no B and T cells at all. This is that movie. Have you ever seen that movie with the little boy that anything could make him sick and tried to keep him pretty much in a plastic area in his room? And he eventually came out and eventually died of an infection. That is the bubble boy's disease. That goes all the way up to the child, starting from the get-go. If you're lacking T cells, they call it DiGeorge. In that case, what do T cells attack? Virally infected cells. So the person tends to get, where is it? Viral infections. But they still have the rest of their immune system, so they tend to be resistant to right there, bacterial. So think about your logic. You lose your TC cells, you probably have that kind of infection. And that's just the way it falls. B cells, sorry to tell you, it affects gentlemen more. This case is the flip side. We tend to get more bacterial infections if the rest of the system pretty much takes care of viral, fungal, etc. And then you can have single classes. This is the one I told you about before. IgA is the what antibody? What's the nickname for it? The secretory antibody. Found in all your what? Your secretions and mucous membranes. If your lungs don't have the IgA, the child tends to get more lung infections. The intestines have no IgA, you get more infections. And older people, the first cell to go when you're older, or one of the first, is the TC cell. TC cell goes after what? Virally infected and cancer. What do older people get more of? Cancers. If you keep them alive, maybe that would help us. Yes, stress has an effect. When they tell people who have cancer to keep them calm and mentally constant, stress produces glucocorticoids. That is toxic to TC cells. TC cells, relating that to the top, is the immune cell that goes after abnormal cancer cells. So if a person's, and we're not talking about stress for a day, if a person's constantly stressed, their TC cell count is going down, they're more prone to, if they already had, certainly, cancers. Yes, the balances in your mind do matter. AIDS, I'm just going to say, can have a lot of relevant infections because everything becomes an opportunistic pathogen. Shingles means the person, before they had AIDS, probably had chickenpox. Nervous system, any sort of meningitis. Toxoplasmosis is a you can get from their cat. They clean the cat box. So not just pregnant women, but also AIDS patients. Okay, and of course everything else you can add to that list. Now, I'm going to switch to the handouts. I'm going to do the first one. Actually, no, I don't want to switch to handouts. I'm going to hold on. I want to finish up one more thing. I want to finish one more thing on another chapter. This is the review, so don't panic. Focus notes. I said I wanted to finish with this, and I'll finish with the board and have to do the handouts next time. I'm going to page 9. I said I wanted to at least show you this, and as you do need to know it. The immune system cytokines. Immune system cytokines. And so this is the adaptive immunity. After this, I'm going to draw one more picture on the board, and I will do the handouts and do a review on Thursday. Handouts are just a little before Thursday. It's like this does this does that. This illness is this illness, this illness is that illness. It's straightforward. I am going to go over Thursday. I said, when you have the football, or you have the relay race, or you're having coding of the immune system's activation, that chemicals are also released. The group of chemicals can be called cytokines. We even mentioned with the mast cell that one of them is IL, which is interleukin. What's a leukocyte? It's a white blood cell. Well, so as it says here, cytokines are released for communication, to increase inflammation, to call more immune cells to come attack to the area, and etc. I'm going to go over 2 of these. Here's the one we just mentioned with the mast cell, and it can do other things. Signals between cells. Came from the what cell? The TH. Aren't you tired of hearing about interferons? They come from virally infected cells. They can also increase phagocytosis. And how do they stop viruses from spreading? They shut down protein synthesis. So you already know this one. And you already taught this one with the mast cell. Growth factors I also mentioned. Growth in microbiology doesn't mean bigger, it means a greater number. So if you're having a fight, what you want 10,000 immune cells fighting versus one? That's probably a little. Tumor necrosis factor, I'm try to do some research on it. Essentially, it helps with inflammation, the immune response, and it does kill tumor cells. It's not a magic solution. They have tried to use this and boost up the immune system, killing tumors, but it hasn't worked for clearing people of cancer at this point in time. Does that mean it will never work? No, it could work at other times. Cytokines, I said this a long time ago. Monocyte is rolling through the blood vessel. Some sort of signal comes from the tissue and tells them to stop. And then he will then squeeze through the walls of the blood vessel, differentiate into a macrophage, and attack. Well, here it is. Some sort of signal, positive chemotaxis, signals to go into the site. So chemokines is one name, and there's more than these. There's like only 6 of them. There's more than this. Okay, I have 2 subjects so I'm going to get both of them out. I'm going to draw the board now. And yes, I know I need to do the handouts and autoimmune disorders, but they're straight memorization. So do look at those before we get back. I'm not sending you away. I've got some work to do. Okay. What? Maybe it's not. Okay. 2 things I want to finish with. We've talked about vaccinations. We talked about testing people's plasma or serum to hunt for things. We talked a little bit into the chapter on autoimmune disorders, which I'm going to go over as handouts later. This relates to a test. No, not the 50-question test with multiple choice. They're all falling are true except which y'all know. This is called an immunochromatographic dipstick. How's that for a name? Immuno because it has to do with antibodies. Chromatographic because it changes color. Dipstick because this is dipstick, not this one. Okay, now listen. This is how it starts. Antibody-antigen complexes if they match length, correct? This is dry. A sample is placed here that can have a certain antigen, epitope tag. If this is wet, put down as some sort of fluid, and this is all dry, it has to wick up, correct? First it's going to come to some sort of site that has antibodies to the antigen. Okay, you're going to get the what? Antibody-antigen complex. And there's going to be more than one. But nothing's happened yet. It's still going to go up because there's nothing to stop it. Somewhere up here, depending on where they put it, they have a fence. Y'all ever seen the wind blow papers or newspapers up against a chain link fence? What happens? Everything blows up and stops. This has, did y'all remember the ELISA? Antibodies to the antibody. But they are tied. They are tied to this area and they cannot go anywhere. If again you get your sandwich and they match, they're stuck, aren't they? They're stuck. And there is an element in here that causes a color change if the concentration reaches a certain area. They have other compounds and chemicals in it. You know what this is? Hey. Immunochromatographic dipstick. Checks for antigen in a person. Fluid used. Flows up. Has antibodies, anti-antibodies that causes a color change. As a pregnancy test. It's a pregnancy dipstick. Okay? They're in your home. Well, maybe, I'm not saying that. Okay, I'm not going to say that, I think it's in trouble. Last thing I have to tell you is in 2.5 minutes, which is more of a research level point. Now, I've already told you, and yes, I will do those handouts later, but it's gonna be this does this, and this does this, and this does this. And a review Thursday. Some people, you already heard this, some people tell you that everybody has cancer. All of us have cancer. Now, that's a theory, I'm not telling you it's true. But most people have blood cells that flow through their body and destroy any cell that goes rogue. They have the what? The TC, lymphocyte. And that maybe a cancer will sporadically appear here, cleaned up. Sporadically appear there, cleaned up. Sporadically appear here, cleaned up. That's one theory. Other people say that's not true. Some researchers have now pulled out the TC cell. What do you do with the TC cell? Activate it, feel patterns, but they take the tumor from the person and they use patterns from the tumor from the person for the person's own TC cells. Activate them, get them to have cytokines called growth factors, increase their number, put them back into the person, and those TC cells target the person's own cancer. That is a research point right now. Is it curing people? Is helping what they're still looking at. That's all I have to say.